in mortality. The overall survival after 21 years in those who had this composite treatment was increased by about 8 years, and there was nearly 50% reduction in microvascular as well as macrovascular complications. And also CVD event, time to CVD event was decreased by, increased by 8 years. So that's, overall comprehensive benefit by comprehensive management. But very importantly, out of this, HbA1c, as we have known from this UK-PDS study, with 1% reduction in HbA1c, there is 14% reduction in MI, both fatal and non-fatal, and 12% in stroke, and 16% in heart failure. But very important, something which we always overlook is the peripheral arterial disease, which is decreased by about 40%. So that's a big role of glycemic control as well. So 1% HbA1c can reduce the microvascular endpoints by about 37% and 21% reduction in diabetes-related death and any endpoint related to diabetes. So poor glycemic control. Now we have not only data of the UK-PDS, but even recent first-year glycemic control is significantly associated with long-term complications, including macrovascular complications. Now, not only glucose control is important, but weight is another aspect of diabetes management, which was not looked into because we didn't have good agents that time in the STENO2 trial. So even 5% weight loss can prevent diabetes, which has been shown in the DPP studies, can be helpful for NFLD, PCOS, and dyslipidemia. But if you have to have greater benefits, we need greater amount of weight loss. 10 to 15% can reverse NASH and have beneficial effect on obstructive sleep apnea. But for diabetes remission, we require 15% weight loss. And we have still the benefit, the higher the weight loss, higher the benefit on HbA1c, blood pressure, and triglycerides. So overall, weight also, is a very important aspect which has been highlighted from last year's ADA-AST guidelines as well. So, legacy effect is something which we require. So immediately 1% reduction after diagnosis, as I was talking, the first year is very important because that reduces the risk of all-cause mortality and MI by about 20%. And over 5 years, significant reduction and significant benefit as well. But delaying that up to 10 years, not only that, even after 1 year also can lead to significantly lesser benefit and significantly increased risk of harm. So we have to get to target early on as quickly as possible. And as the UK-PDS has shown, try to maintain it for as long as possible. And you have now data about 40 years of UK-PDS follow-up showing significant benefit of glycemic control as well, which was there in the initial 10 years. So legacy effect on metabolic memory is very important. And we have the GLP-1s, which is an endogenous incretin hormone, which has multifaceted effect. It decreases, it actually modifies the insulin secretion in a glucose-dependent manner, decreases glucagon secretion, decreases hepatic glucose output, decreases gastric emptying, improves satiety, and also has significant cardiovascular benefit as well. Now, with regards to previously, we only had the GLP-1 because that being a protein, we couldn't apply it orally. Now, the oral semaglutide was the first oral GLP-1, which showed a significant benefit in terms of HbA1c reduction up to a tune of 1.5%, weight loss more than 5% in majority of the patients. But very importantly, what is very important that the early initiation of oral semaglutide right after the diagnosis of diabetes helped in achievement of control, compared to those who were initiated later. So the twin objective of weight loss as well as HbA1c reduction was achieved by early introduction of semaglutide compared to a later introduction. So almost 30 to 50% higher chances of getting those twin targets, as weight loss as well as HbA1c less than 6.5. And early on, we would like to go hard, hit hard, and try to bring the HbA1c below 6.5%. Now, we had recently presented this abstract in ESICON 2023, where we were looking into the real world data across India in the Pioneer Real India study, where we used SEMA. This is just the patient profile who were selected. And what was very encouraging was the fact 1 in 2 patients, that is about 50% of patients, were initiated within 1 year of diabetes diagnosis. But what is very important also and concerning is that about 1 in 2 participants had a cardiovascular medical history, and the primary driver was both HbA1c as well as weight as well. So very important, we need to initiate this early, as probably the practice is changing. Very important, we need to evaluate for cardiovascular disease, and this medication remains a very important agent for getting the triple objective: cardiorenal benefit, glycemic control, as well as weight reduction. So again, if you compare with DPP-4 inhibitor, there is significant HbA1c lowering 0.8 versus 4.8 with sitagliptin. So that's quite obvious. That's similar, much more effective. The GLP-1, especially oral semaglutide, one of the most effective GLP-1s. Again, when we compare weight, again, we are all aware, HbA1c comparing to SGLT2, which was also similar, 0.8, 0.9% HbA1c reduction. With EMPA, it was 0.9, and again, 1.4% HbA1c reduction with SEMA. So obviously, HbA1c reduction crosses 1%, nearly touches 1.5 in majority with semaglutide, which is not seen except probably with sulfonylurea and to some extent with metformin, not with the newer other agents like SGLT2 or DPP-4 inhibitors. And if the HbA1c is more than 9%, we can have more than 2% HbA1c reduction. Again, weight reduction is something which we do not expect with DPP-4 inhibitors, whereas we have about 3 to 5 kgs weight reduction with semaglutide, which was seen in this Pioneer 3 trial. Again, numerically more weight loss, 3 kgs versus 4.8 kgs with SEMA compared to empagliflozin. So it didn't reach statistical significance, but there was numerically more weight loss, better weight loss. Generally, this is what is seen with GLP-1. And again, what happens with EMPA or all the SGLT2 is that there's some increase in appetite as well, which if we actually combine this can be a great combination in terms of weight loss as well as suppression of appetite. So, we can have a significant patients population who can achieve the target HbA1c in 60 to 70% with different combination, as monotherapy, as dual therapy, and also with insulin. And if we compare with liraglutide also, this is more effective in terms of weight as well as HbA1c reduction compared to EMPA, SITA we have already seen, and even with insulin. And that's something really great. So along with that, there is weight reduction through appetite suppression, and there is decrease in energy intake and food consumption as well. So energy intake, with ad libitum was significantly decreased with semaglutide as well. And there was decreasing food cravings, and there was controlled eating, especially with regards to portion size. But what is very important, that still the pleasure of meal was intact. So that's very important as well, because as I will be talking about, so otherwise there is some thought that whether these agents can be associated with some depression or any other suicidal tendencies, but that has been also addressed in most studies showing it's neutral. Again, there is a significant waist reduction, waist circumference reduction, which is associated with increased risk of atherosclerotic disease, cardiovascular disease. This is a very recent publication which was just published a week back in Nature Medicine, which showed that semaglutide was not associated with any suicidal ideation. This was a network meta-analysis, and again, in both subsets, whether it was used for obesity at a much higher dose or even as an anti-diabetic agent. So there was no high risk, there was no increased risk of suicidal ideation, which is very, very, assuring to all of us, reassuring to all of us. So in the clinical attributes of oral semaglutide, superior HbA1c reduction, weight loss, and better efficacy as well. In patients with CV risk factors, especially this 47-year-old male, 9% HbA1c with hypertension, dyslipidemia, already on triple agents, metformin, SGLT2, DPP4 inhibitor, and the major concerns of HbA1c and comorbidity and our family history of CVD. So we have multifaceted cardiovascular benefit with regards to use of GLP-1, which we are all aware, from endothelial function to natriuresis and decrease in inflammation. And we had been reported few of us patients early on as well, including patients used early on as well as with cardiovascular risk with these agents as well. So there was in the Pioneer Real, there was a non-significant 21% reduction in MACE. This was mainly a non-inferiority trial, not a superiority trial. So this was very, very reassuring. No cardiovascular risk and suggestion of numerical benefit. Again, what was important is that there was nearly 50% reduction in CV death and all-cause mortality as well. So that is really reassuring as well, though it was not a superiority trial. Again, blood pressure, there is about 5 millimeters of blood pressure reduction, which is associated, as we know, significant benefit of heart failure and stroke, apart from ischemic heart disease and death as well. There is a reduction in LDL and triglyceride, which, dyslipidemia associated with much higher risk of cardiovascular disease, especially in the background of diabetes and hypertension. And also there is reduction in CRP, which is a marker of tissue injury and inflammation compared, and even that, beats the empagliflozin in terms of reduction in inflammation as well. So if we choose, when it comes to the choice of anti-diabetic agents, especially when it's oral, which we are, now, we can use these agents much earlier, as we had shown in the abstract as well. So you have the benefit of glycemic control, weight loss, CV risk factor modification, pleiotropic benefits, and minimal hypoglycemia as well. So this is, in a nutshell, we have all the benefits, and we need to choose our patients and use them properly, and also apply the guidelines where it is appropriate and necessary. Thank you.